Okay, so thank you for joining us for tonight's webinar, which is Quality Improvement Activities in General Practice. My name is Bertha Harvey and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respects to elders past, present and emerging. I would also like to extend that respect to any Aboriginal colleagues joining us here tonight. I would now like to introduce our first speaker for this evening. So Kimberly Colton, who is the CPD Program Coordinator at the Royal Australian College of GPs. Kimberly will be providing a quick update on the CPD activities, as well as some resources and new tools to assist you with logging your activities. So welcome, Kimberly.
Okay, so what I'd like to do tonight to start with is to go over some things about CPD, the CPD requirements for this year, so starting from 2023. So if you remember, there are a total of 50 CPD hours. We've moved from points to hours, so 50 CPD hours required to complete this year in 3 different CPD types. So if you look here on the My CPD page, you can get a good idea of your progress in your CPD by looking here on the left-hand side under Annual Requirements, Educational Activities being your very first CPD type. You're required to get a minimum of 12.5 hours in educational activities, and these are activities in which you receive knowledge through a presentation such as a lecture, a webinar such as tonight, maybe it's a podcast, maybe you're reading journal articles. It's when you're receiving knowledge from a source. Those are your traditional sort of CPD activities, like conference sessions, for instance. The second type is reviewing performance. Reviewing performance hours and measuring outcomes have to total a minimum of 25 hours. You should have 5 hours in each of these 2 different types of CPD. So if you're someone who finds it difficult to meet or to complete measuring outcomes, you would only maybe strive to reach your minimum of 5 hours, meaning the remaining 20 hours would have to be reviewing performance, and vice versa. Review and performance are activities in which you are more engaged. So that may include workshops that are hands-on, small group discussions, such as case studies, perhaps practice meetings, which can count as review and performance, even multiple choice questions. Multiple choice questions, because when you answer those and you get feedback, you're able to kind of review your performance, what areas you know really well, and others that you maybe have gained knowledge about. Measuring outcomes are those that are a little more difficult for a lot of GPs unless you do a lot of audits. Audits are typical example of a measuring outcome, but any type of quality improvement activity can serve as measuring outcomes. You may be improving the way in which you recall your patients, or you may be improving a system that's something that's not working well in your office. Perhaps you've done a patient survey to determine how you might improve the environment in the waiting area. So there are a number of different things that you could include as measuring outcome because it's quality improvement. It's something that you're working on and have made a significant improvement on in your practice, whether it be the way you manage patients, the way that and their conditions, or the way in which systems work within your office. So the last remaining category is any CPD type. So essentially, once you've completed your 12.5 hours of educational activities and your 25 hours of reviewing performance and measuring outcomes, the remaining hours will fall into this last category. So it's sort of like an overflow. And once you've completed all the activities, the ring will become completely colored in. So you can see in this case, they've actually completed their minimum 5 hours in these 2 categories, but they haven't quite finished the full 25 hours here. And they also have a few more hours to complete here in the overflow category. So those are your 50 hours of CPD. The only other thing that is required this year is your professional development plan. And that's where you basically outline the things that you would like to accomplish for the year. Ideally, this should have been done early in the year, but it's all a learning curve, and some people are just now getting to it. But there are two ways that you can complete that using the RACGP tool, which actually gives you a list of questions that you can work through, explaining your situation, what sort of things you'd like to achieve this year, etc. And then when you finish, toward the end of the year, you'll go back and reflect on that to see how well you've done. So those are the CPD requirements for the year. Remember that CPR is only required every 3 years, so you will not have to complete CPR until the end of December 2025. Now we do have a couple of exciting new things added to our log function. So the log function here can allow you to self-report activities, obviously through QuickLog. You can do CPR, your advanced life support, and you can upload GP-led activities such as practice meetings using the GP-led activity tool. But the new tools that we've just added are the measuring outcomes tool, which I think is very timely to discuss tonight. If you click on that, you can actually go and use this form to describe the changes, improvements you've made in your practice. So let's say, for instance, you've attended an activity where you learned a lot about the management of diabetes, and you learned a few things that you'd like to kind of implement into your own practice. This is where you would go to this tool, provide a name for your activity, something meaningful, and then how many hours you've spent would be measuring outcomes. When you started to implement the changes, okay, so your date, and then you answer a few very simple questions. What changes have you implemented in your practice as the result of your recent activity completion? So what sort of things did you change? There are a few examples down below if you're having a hard time thinking of what sort of things we're looking for. The second question, how do or will you monitor the effectiveness of these changes? So after you've implemented it, you want to think about how you're going to monitor and ensure that those changes are actually working and have improved the system or management of the patients, if that's what you're looking at. And thirdly, what evaluation process do or will you use to measure these? So will you be conducting a survey? Will you be just looking at a checklist and seeing how things have improved? Are you going to look and see if maybe you have a list of targeted outcomes and you want to list those there? And with all of our other tools, and here as well, you can choose to upload a file as evidence. This is optional. However, keep in mind that you do need to have some form of evidence for every activity you complete, should you be audited by the RACGP, or more importantly, by AHPRA or the Medical Board of Australia. If we return back to log, we can actually look at a reflection tool. Again, if you've completed maybe an educational activity and afterwards it really resonated with you and you've had a lot of ideas and thoughts around how you might incorporate some of that or how that fits against what you're already doing, you can complete this activity tool by putting in, again, a meaningful title. Depending on how many hours, you'll enter your reviewing performance hours. Because anytime there's reflection, it's seen as reviewing yourself, reviewing your performance as a GP. The questions are what, so what, and now what. So what? Describe the learning experience and how it relates to your scope of practice and or your professional development plan. What did you learn from the experience? And what will you do differently? So what changes might you implement as a result of the activity that you attended and your reflection on that? Again, there's an opportunity to upload evidence if you had some. And that could be notes. It could be perhaps a picture of notes that you have or something you've stored on your phone, and you can upload that as evidence. Again, that's optional, but you should always keep track of your evidence in case you require it. Okay, so that's the latest with My CPD and here at the RACGP, your CPD home. And if you have any questions or you require assistance with any of this, please feel free to call the New South Wales ACT Faculty CPD office, and we'll be happy to have a chat with you. It will be either myself or my colleague Angelique Terry. Thank you.
Thank you, Kimberly. Some exciting new tools for GPs to use. I'm sure that they're greatly appreciative of that support. So our next presenter is Kaylin, who is a Digital Health and Quality Improvement Officer at CESPN. And following Kaylin, we'll have Jan Sadler, who is the Manager of Practice Support and Development also at CESPN. Thanks, Kaylin.
So as Bertha mentioned, I'm one of the Digital Health and Quality Improvement officers here at CESPN. As the job title suggests, one of our big focuses is helping you with quality improvement activities using your practice data. So in general, the digital health team here can help provide support to general practices, aged care, allied health, and specialists. And we provide support in a number of things such as PIP-QI, My Health Record, secure messaging, eScripts, Lumos, telehealth, and training with PenCS and Polar extraction tools. So Pen or Polar are both fantastic resources that can help you analyze your practice data, which includes looking at clinical data of your patient population as a whole, key accreditation indicators, as well as financial data. Because these tools are a great way of viewing your overall progress as a practice, you can also use it as a way of achieving CPD hours for measuring outcomes. With the use of these tools, we can provide you with quarterly reports that measure your practice progress around the 10 quality improvement measures or QIMs and key accreditation indicators as well. So tonight we will be looking at how to set up a quality improvement activity in relation to your CPD requirements for measuring outcomes. But if you would like to set up a personalized one-on-one session on how to practically use Polar or Pen, or even for installation of this software, please feel free to reach out to the digital health team. As Alison will mention in her presentation, it is important to keep a record of your quality improvement activity, not only for your own records, but in case you are audited. Although you are free to record it in your own way, such as if you would like to make your own template, that's fine. However, our team also provides a number of PDSA, Plan, Do, Study, Act templates on this web page here to make the job easier for your practice, or you may even choose to adapt these templates to your own liking. So this website also includes pre-filled templates for specific quality improvement activities, which covers the 10 QIMs, immunization, hepatitis B, and intellectual disability. And this is our contact information here if you have any questions regarding this. Thank you.
Hi, everyone. I'm Jan. I'm the manager of the Practice Support and Development team at CESPN. I just thought I would do a very quick overview of the and linking in with these quality improvement activities. It's really important to ensure we understand the requirements also for the RACGP 5th edition accreditation standards. So here are 4 indicators set by the College for accreditation, and these are a must do when you are going through accreditation. The first indicator is our practice has at least one team member who has primary responsibility for leading our quality improvement systems and processes. And you must, this is a must, you must educate the team with primary responsibility for quality improvement activities in the practice about their role. So you could document responsibilities of this role in the position description of that person, or develop quality improvement team made up of members of clinical and administrative staff. And that's ideal if you can do it as a team for sure. The second indicator is our practice team shares information internally about quality improvement and patient safety. So you must have a system to identify quality improvement activities within your practice. So you could allocate time in each team meeting to discuss quality improvement systems with your practice team, or you could keep a record of planning meetings where quality improvement activities are discussed. The third one is our practice seeks feedback from the team about our quality improvement systems and the performance of these systems. So you must keep a record of feedback from the practice team about quality improvement systems. So it's a very much a team approach. So you could, in that instance, have a notice board in your staff room or suggestion box for your team, so they can contribute to some ideas of quality improvement activities. You could create little surveys for the team to complete that are incorporated into a quality improvement plan for your practice. And on that documentation, don't forget that, with the PIP-QI, that you must keep documented evidence of your quality improvement activities in case you get audited also. The fourth indicator is our practice team can describe areas of our practice that we have improved in the past 3 years. So you must keep records of quality improvement activities to the practice or practice systems in response to feedback or complaints for audits. So you could keep minutes of meetings where improvements to the practice are discussed, have a system for developing, mandating, implementing and reviewing policies and procedures, or you could include quality improvement as a standing agenda item in a team meeting and your minutes. So they're the indicators for the quality improvement with the RACGP accreditation standards. And obviously there's indicators around health summaries that you need to meet for that. And that's where our quality improvement activities can come into place, and we can support you, and the digital health team can also. I'm just showing you a slide here and what the practice support team can help you. If you need any support, please reach out to any of our teams. And one of those is definitely around accreditation. If you're going through accreditation, please reach out. We're very much supportive of this. We can go through a plan for you over the time period, so it's not an arduous process, because we know it's such a big job going through accreditation. And if you want to contact us, that's our email address at the bottom, or you can call us at CESPN. Thank you.
Thank you, Jan. And moving on to our final speaker for this evening, we have Dr. Alison Vickers, who has been a GP and practice owner for 35 years and complemented this with work in medical writing and medical education. Thank you, Alison.
Thanks so much for inviting me to share my journey in general practice with quality improvement and how it's affected our CPD. And I guess I have been in practice for 35 years, started in 1988. And in 1988, there was no accreditation, there was no formal CPD, and there was no formal quality improvement. And I just want to say that even without that, I really think that most GPs were engaging in CPD and also in quality improvement. And I know there was a lot of activity that was probably not as formal. But general practice changes, and we have to change with the times. And there's certainly a lot more requirements and a lot of changes over that 35 years. So we've got accreditation now, and that seems to be getting bigger and bigger, and there seems to be more and more about quality improvement in that. We've got if you get the practice incentive program, you have to do quality improvement activities to qualify for that, as well as sharing your data and getting those benchmarks. And of course, CPD points, which we've seen the big change to recently. And look, I think we're all trying as GPs to get our head around the changes, and it is tricky. And I don't think that I've necessarily got my head around it properly yet. But I think it's actually, in a lot of ways, in terms of how it's fitted into our practice, it's been a good journey. It's actually been better because there's so much flexibility in it. And over the years, there was so very little flexibility. It had to be approved activities that you did. And I think one of the really big things is that there's absolutely no doubt, it's a no-brainer, that if you do a quality improvement activity, there has to be some sort of education, there has to be some planning, some researching, and then you're also studying it and seeing whether it works. And it kind of fits so well with the CPD. And I think if you go to do any education, any CPD, that has to be a quality improvement in what you're doing. And in our practice, I think one of the most important things, and one of the things that's been really good for us, is that the CPD hours and the way it's set up now has helped me lure our team into doing quality improvement. And to be honest, everybody's so busy, and I think it's often quite hard to get all of the GPs involved in doing the quality improvement, even though you're doing it for the practice. So here's our team that have at times been reluctant. And this is kind of, I guess, a case study from how it's played out in our general practice. And our general practice is probably not typical, but hopefully you'll be able to extrapolate into your practices, which are probably much bigger. We're a small practice in Miranda in the Sutherland Shire. We've got 3 GPs, but really probably 1.5 full-time equivalents. We've got a practice nurse, a psychologist, and a speech pathologist. And we've got 1,550 RACGP active patients, which I got off Polar yesterday. My role in the practice, I do 2 days of general practice, and I do quite a lot of the practice management. I organise our CPD. I am definitely the person responsible for all our quality improvement activities and accreditation. And I just want to say again, I am no expert in either of these things. And it's great that we got Kimberly here. As I go through what we're doing, I've asked her with a pen and paper to write down where perhaps I've thought this is an activity and it isn't, that it will be a good learning exercise. I also really appreciate the help that I've had from the PHN in terms of helping me with Polar, helping me to understand the measurement tools. And I think there is good help and support out there, because it is a confusing and difficult journey. But no matter the size of your practice, a lot of practices will need to be doing quality improvement activities to get their PIP, to be part of their accreditation. And now, of course, all of us are having to do the new CPD. And, you know, people like our practice nurse psychologists, they're after CPD hours as well. And I think this CPD has been a bit of a grand opportunity, because in our practice, everyone was really stressed out about the new CPD, me included. And so I kind of suggested, well, why don't I have a look and see if I can understand what it's all about. And rather than us all doing our CPD separately, let's try and do quite a lot of it as a group, and kind of go on this journey together. So it really presented an opportunity, and we had a meeting all together, and I guess we got to meet in person, but you could do it on Zoom, you could probably do it in a chat. And we decided that what we would mainly do we would do a lot of our planning meeting together. And then we just add to it stuff that we wanted to do on our own. And the main thing we'd do face-to-face peer group learning. And that would really suit us all. And we'd meet the first Thursday of every month at 6:30 with dinner, which kind of also made it really nice and social. And we'd never done anything quite as social apart from practice meetings and before, and not as regularly. So really, this gave us a huge opportunity for basically all sorts of CPD planning. We kind of planned what meetings we were going to have in our peer group learning, and we decided we'd do 30 hours. And the topics that came up, and it was funny, we'd all sort of been thinking about the same topics, were cardiovascular risk. We wanted to also look at, you know, common investigations for presentations and interpretation of common pathology. We'd had a bit of few patients trying to stop alcohol, and we decided we wanted to do something on alcohol and smoking, diabetes, pharmacotherapy, men's health, long COVID, and emergency medicine, because we're all terrified of emergency medicine. So it was going to work out to be 30 hours, because we would have 2 hours every month, and then we'd have a 6-hour day to do the emergency medicine. And it kind of fitted so perfectly, because at that time, I'd been looking at the kind of quality improvement activities I wanted to do for our PIP. And one of them was cardiovascular risk. and the other one was smoking. So I thought, like, two birds with one stone, we can do all of this education, and at the same time as a group, we can do our PDSA activities. So it was kind of an excellent opportunity to do these two things together. And in our practice, it's worked out pretty well. We looked at the kind of things we could do, and I have a handout here that I've laminated, which was on the RACGP website with different activities and what groups they might have fallen into. And so I've kind of been using that. But we had our face-to-face peer group learning, which was reviewing performance. Our meetings also then would have half an hour afterwards just to look at our PDSA activities, which is measuring outcomes. And then we could also include any time we then spent kind of in the actual doing of the PDSA activity. There was a lot of preparation of PowerPoints and presenting. I'll be honest, most of it was done by me because I was not doing as much GP work as they were, but there was opportunity. Some of them said, I would like to do something on that. And then for them, they could prepare a PowerPoint, research the topic and present to the group. So that was kind of like an educational activity, but also was down as a measuring outcomes. We researched and developed guidelines together, like for the diabetes particularly, we did a guide for how the pharmacotherapy we wanted to use in the practice. We developed templates and patient materials, reviewed case studies, and it was nice. We had a multidisciplinary team. We had our practice nurse there, the speech pathologist not so much, but the psychologist loved it all. And she actually had some great stuff to add to the meeting as well. So the first one we did was cardiovascular risk, and it was already a planned PDSA. The reason being, like, these really bad statistics that we had only had 28.6% of our patients that should have had a cardiovascular risk assessment in, or had everything entered so they could have cardiovascular risk. Very embarrassing and very surprising. You always think you're doing better than that. And so it was kind of like a great opportunity to say, well, there's something measurable that we can look at. But we also had wanted to do it because we really felt that it was something that was extremely important in terms of the fact that heart health checks save lives, getting people to target, and maybe we weren't always doing as well as we should. We also thought we could improve our practice income by doing some heart health checks, or item 699, which we'd done a little bit when it first came in, but then we'd kind of gone off the boiler and stopped doing them. And we thought maybe they'd finish at the end of June. So we thought, well, let's see how many we can get done by the end of June. But of course, they've extended it. And one of the clinical areas we really wanted to look at is our understanding about the different statins. Which one would we choose? Why would we choose it? What was the benefit of one over the other? So we could have a kind of guideline in our practice for what we would generally use, what dosing we would go to, when we would use another statin, and also looking very much into risk benefits so that we felt informed in terms of helping our patients. So we set the goal that by December 2023, we would have increased the cardiovascular risk recorded in our practice to 50%, so we didn't set it too high, and to have completed 100 heart health checks. We started with 50 by the end of June, and then we changed it to 100. So that was our goal, and we set about achieving it with the PDSA. Now, I don't know, I did have a slide going through the PDSA, but I think anyone who's done quality improvement has probably had to try and fill out one of these forms, or sometimes I use my own template. But it's really about having come up with some ideas where you think you can improve something in the practice, where you've set yourself a goal, as we did with the cardiovascular risk, to say, okay, we're going to get up to 50% of those observations in our software, and we're going to do all those heart health checks. So you've got your goal, and then you plan how you can do it. And so you set out a whole lot of things that you're going to do to plan it. So for us, it was about having the peer group learning, developing the template, sending out a newsletter, putting it up on our notice board, encouraging patients to have heart health checks. So then you do it and you look for problems when you're doing it. You study the outcome and see how well you're doing, how much it's going up by, and then you make changes to do it again. So I've been filling out the PDSA form, and I have to say, I mean, I'm a GP, I'm not a quality improvement expert, so I don't know if I'm filling it out correctly. And I did a bit of research, and evidently there was a systematic review in the BMJ, which showed that, you know, we're all doing our best, but often we don't fill them out correctly. But I guess we just have to keep doing our best. As I said, we're not quality improvement experts. So basically, we started off with the PDSA, so there was points for that. Then we did our 4 hours of peer group learning, which turned into 6 hours reviewing performance, which was very active, very engaged. Obviously had to do research, develop PowerPoints, do the presentation to the group. And what we found is that although it seemed simple, as we looked more into it and we talked about it, there were a whole lot of questions that we had that we couldn't answer, you know, where there were gray areas as to whether we put someone on a statin, what is their, you know, their cardiovascular risk versus their calcium score, when would we get calcium scores? And as a group, we came up with a whole lot of questions, and I contacted a lovely local cardiologist, and he was fantastic. He met with me one afternoon for an hour and a half. He prepared a PowerPoint. He went through all the questions, and then I reported it back to the group. And that then we came back to the cases that we weren't sure about after what he'd said, and we looked at, you know, our decision before and after the specialist input, and it really added a lot of depth and texture, and plenty of CPD hours that probably fitted into reviewing performance. We also redeveloped the template for the heart health check. Everybody had a little bit of a say in what we wanted to do. It was probably a bit too long, so we cut it down a bit. And we developed our guideline and consensus in terms of statins, which has really been great in terms of when you're seeing patients, giving you a lot more confidence, and also that we're all kind of doing the same thing. And in the next meeting, we're now going to obviously look at the new cardiovascular risk calculator, which is just so much better, because we were using the Australian calculator, but also the calculator from the UK. So quite excited about the new calculator, especially the fact that you can put in the postcodes. It's really quite staggering to see how much your where you live affects you. And how well are we doing? Well, not fantastically. We've done 53 heart health checks, which I guess is pretty good. We're on the way to our target. But our cardiovascular risk from POL is only up to 32.3%. So we studied that and went, why? Why isn't it going up? And then we realized that even though we were trying to enter cardiovascular risk, one of the doctors in the practice, my husband, he puts the blood pressure into his notes rather than into observations. So that was why we weren't registering as having as many as we should. So we're acting now. All the pressure is on him to start putting the blood pressures into the observations, and we hope to see that figure go up much higher. It is kind of cool to have a measurement to have a look at, and that's why, you know, things like POL are really, really quite fun. It's just, it can take some time to get to learn how to use them properly. And I had some great help from Kaylin from the PHN in terms of my skills increasing, which was one of the reasons that I wanted to do this, because I thought this is going to make me get better at it. The second one we did was to do with smoking and alcohol. As I say, already it sort of fitted into a quality improvement activity and a PDSA that we planned. And again, because our figures were terrible when we got them, only 56.8% of our patients had their smoking recorded. And I was like, I can't believe this. And I went in and had a look. It's all the 15 to 30-year-olds, and it's because they started in our practice as children, or they were born into our practice. Don't forget, we've been there a very long time. And of course, we haven't kept up. We haven't recorded their smoking history as they've got to be 15 years and older. It's an important thing to do. Also, when we were doing the cardiovascular risk, we had quite a lot of questions about vaping. And so we're going to, one of the GPs wants to research and present on vaping, which I think will be something that will really help us in our practice. Also, the psychologist was great because, when we're talking about how we motivate people to make lifestyle changes for cardiovascular risk or to get their, to get their cholesterol down, etc. We were all into, look what can happen. Look at your cardiovascular risk. And she was like, you can't use fear as a motivator. So she's going to do a presentation for us on motivation and motivational interviewing. So, that's the benefit of it being multidisciplinary. The other thing is none of us have ever used the stop smoking item numbers. That's probably not their official name. So we're going to have a look into that as well. So our goal is that by June 2024, we'll have 90% of smoking history recorded. So try and make the goals the SMART goal, where it's a bit specific and measurable. So again, this has meant CPD activities for the team from this quality improvement activity that fitted so beautifully with our face-to-face peer group learning. So for our PDSA activity, I've printed a list of all the patients who don't have a smoking history recorded, and everybody's got a copy of it. And it's for us GPs and the practice nurse to try and cross them off, and we're going to have a bit of a competition to see how many we can get done. And in terms of at the front desk, we don't want to take those histories at the front desk. So we're going to develop a questionnaire for patients to fill out and hand it out to them. So if the GP doesn't have time, or they can go in and hand it to the GP. And if we don't win with that, we may do a self-form fill that we basically email out to people. In the peer group learning, as I said, we're going to have the psychologist talking to us about motivational interviewing. We're going to talk about pharmacotherapy, about the item numbers. So, peer group learning is reviewing performance, developing a questionnaire, I guess if we see the outcome of it, measuring outcome. And Kimberly, you can, as I say, I'm just taking it from the sheet, PDSA activity, measuring outcome. And to me, that just makes sense because you study it and you act on what you've done and you're measuring it. And then, of course, for each of the group who do research, who prepare PowerPoints or handouts or present, there are CPD points for that. And then we'll probably develop a guideline for management, particularly in terms of alcohol. We've had a few patients trying to go basically detox who are on large amounts, and we really want to feel confident if we're going to help those ones. And the other thing is one of the patients talked about us doing a podcast on alcohol. And how to decrease alcohol with the psychologist. And this leads me into the kind of, I guess, where individual GPs, someone like me, and I'm sure there are a lot of practices where there's someone who has like a keenness to do other things in the practice. Like for me, I was like, I like doing newsletters, I like doing the website, and I was dying to do some podcasts. So I thought, okay, do a PDSA around podcasts. So I wanted to have a regular podcast on our website by December 23 with links that went out from our newsletters. And the first one is up on our website today. So I'm really excited about it on weight loss with a fantastic dietitian. And I guess for me individually, there's a whole lot of CPD points. Hours. Kimberly, I'm so sorry if I kept saying points. Everybody, it's not points anymore. It's hours. I meant to be saying hours. So there's a whole lot of CPD hours in the PDSA, researching the topics, because boy, when you have to present something like I've done one on the perimenopause, you have to do a heap of research. And even when you meet with someone like with the dietitian, particularly when we were talking about iron, I had to do a lot of research for that as well. And I guess in developing the podcast, there's, and seeing how people respond to them. And already one of the other GPs has said, oh, maybe I could do a podcast. She wants to do some on lifestyle. And so, I'm starting to get somebody else involved who's going to get CPD hours for her as well. In terms of it qualifying for the PIP, I'm not sure. I'm not sure if they would count data as being the number of downloads or the number of followers, but I guess I'll have to follow up and see if that's the case. So I think any idea can be turned into a quality improvement activity, and with a PDSA and CPD, sorry, not points, hours, CPD hours. There are challenges. It's not that easy. I find filling out the PDSA template for the quality improvement activities, I really not sure if I know what I'm doing there. And it's quite boring. So I find I tend to put off doing that. Learning POL or other data extraction tools, it's fantastic. But you need to take time to learn how to use them. Understanding the CPD categories, obviously I'm still on a learning curve with that. And it was just helpful. I wrote down what you said, Kimberly, and I think that that's going to help me. Involving the team is always a challenge. I really think this new CPD, I've involved the team more than I have in my whole time in our practice, and they're all very engaged with it. In summary, we have to formally now do quality improvement activities for our PIP and accreditation. We now have a wonderful choice of CPD activities. Every single improvement anyone in the team wants to make has to turn into a quality improvement activity that you can do a PDSA on. And then there are CPD hours, I did put hours in there, for doing the PDSA and CPD hours for all the other steps along the way. So many opportunities. The PHN can help with extraction tools. Having a measure is quite motivating and fun, I have to say. And completing the PDSA for me is harder than it seems. So I think the new CPD hours are a great motivator to get more of the team involved in quality improvement activities, but you may still have to incentivize them further, and I still do make dinner for everyone on the night. So you may have to incentivize. Everyone's so busy and so tired and trying to do everything. But as I say, we have a lovely dinner together and a chat and a socialize and lots of good learning. And I don't have a picture of our team, but it's a lot of fun. We all look way older than those people. Thank you.
Thank you very much, Alison. Wow, you guys are doing so much at your practice. And thank you so much for your enthusiasm and infectious energy and great tips on, thank you for sharing what you guys are doing. I might ask Kimberly and Kaylin to jump on, and anybody else from digital health or practice support that wants to come on. We've had quite a few questions come through, and thank you for everybody who's been answering them in the back end. But Kimberly, I might start with you. Is there anything that you want to touch on?
Yes, look, I think most of the questions I can say that we have related to different CPD activities are related to measuring outcomes tonight. And I do recognize that there are a number of GPs who aren't necessarily working full-time in a GP practice. And so all of this seems very overwhelming. If you're only working part-time, maybe working as a locum, maybe working, I've had GPs contact me, they're working in aged care, or they're actually working as surgical assistant as a GP. And so those are very different sort of things. And we've had to kind of be creative. And I think this is where you will have to kind of think about it. Measuring outcomes don't have to be these activities don't have to be extremely complicated. Our clinical lead, for instance, has suggested that you consider, if you work as a locum and you're only there three times, over 3 days or something, to look at the patients that you actually are treating and to find an area in which you can kind of think about how you've managed patients with a particular condition or something like that, and just look at 5 patients and ask yourself questions about, what sort of what am I following? Am I making sure that I'm taking the blood pressure? I'm doing this, I'm doing that. What are things that I didn't do with everyone that I wish I had? How could I kind of improve how I approach a patient that comes in with this particular condition? So it may just be a small number of patients that you're looking at. Maybe you work in an aged care facility now, and this is, I actually had someone who said, I recognize an aged care facility. I just happened to notice that someone wasn't vaccinated against, and I forget what the vaccination was for, but anyway, they weren't vaccinated against something, I think it was pneumonia. They weren't vaccinated against pneumonia. And she said, then I started to look around and I realized that a number of people weren't, and that perhaps we needed to change something. And so what we've done is we've implemented a questionnaire to ensure that we're getting that sort of information when the patients first arrive to the facility. Another patient said, you know, I was kind of wondering what my patients thought of how things were running in the office. And so I sought feedback through a very simple questionnaire, but it took a bit of time to create that questionnaire. So obviously that time counts. And then I took the time to kind of read through their responses to see, is there something we could do to improve the patient experience? So it's not necessarily just about management. I think the key is it's in whichever area you're working, how can you, or what sort of improvement could you make? The GP that contacted me, who was a surgical assistant, he said, I work in a hospital. They're not my patients. The protocols in the hospital are what they are. I don't know what to do about it. The suggestion and what he ended up thinking about doing was, okay, maybe I need to just look at the protocols of the hospital. Maybe I need to see, are there things that I'm maybe not always asking that I should be asking? The example was, you know, a patient is allergic to rubber, you know, to latex, and so that would obviously be really, really important. So are there things where I've had near misses where I need to kind of step up my game, or is there something within the protocol that could actually be better? Now, whether that change can be made is another question, but recognizing it and doing what you can within the parameters of where you can work, and for him within those protocols, was something that he saw as being very valuable for himself. So it doesn't have to just be about a patient, a particular patient, and how you're managing that particular condition. For instance, it can be systems. That's something that Allison has brought up here as well, is, you know, it could be systems that need to change. It could be a process or something that you do that just needs to be improved upon. And if you think hard enough about what you do, you probably can come up with something that you would like to see work better. And it may be simply trying to figure out what small change can I make that may make actually a big difference in the end. So I think don't allow this measuring outcome to become too big. Think about quality improvement. I think you do it on a daily basis when you're working. Think about how that fits within your particular context, your work environment, your work setting, and then yeah, try to implement that change and see how it goes, and reflect on it, and determine how to best implement it, but then how well does the implementation go after you implement it?
Great.
I hope that's helpful.
Thanks, Kimberly. I might throw it over to our digital health team or Jan, just to see, I guess, what templates are available and what additional support the team provides.
Sure. I was also going to touch on a few commonly asked questions. So I think Kimberly sort of covered them as well as Allison. But sometimes we get the question whether quality improvement activity has to be in the 10 QIMs, which is, no, you don't have to do it in just the 10 QIMs. It can be anything. It's very likely that you are doing quality improvement in your everyday practice. It's just a matter of kind of looking at it from that quality improvement lens and just keeping a record of it. If you're ever unsure, you can reach out to us and we can have a discussion about that. And also that quality improvement, doing a quality improvement activity once a quarter is a requirement for PIPQI payments as well. So just wanting to reiterate that. In terms of the templates, I can quickly share my screen and show you where on the website we have some pre-filled quality improvement activity templates that you can use for your practice. Just give me one sec. All right. Can everyone see my page?
Yep.
Yep, cool. So this is the quality improvement and PIPQI page on the CESPN website. So if you scroll down to getting started with PIPQI, this section here has a number of different templates that you can use that are already pre-filled and have some ideas of how you can actually achieve or to improve that particular parameter. So some of them are quite simple. So you can even start off with these ones here, which is like sort of like data cleansing, which is finding maybe duplicate patients and trying to even inactivate patients that aren't active anymore at your practice. And then we have ones for the 10 QIMs as well. So this is what one of them looks like. So this is one of the pre-filled templates. So it is an editable PDF, so you can either download it or just type straight into the Chrome web browser, and you can edit them to change it to whatever date that you're starting that activity on and what measure you're looking at, as well as what percentage you're wanting to improve that particular measure by. For example, if you're wanting to have no patients with duplicate files by this date, and you might be looking at maybe a 10% improvement in that measure for that next quarter. And this will also list some ideas of what you can do to try and achieve that. And going to the next page, so this is the plan, do, study, act process. So you would just plan out what steps that you want to take, who is responsible for it, what you did, reflecting on how well that went, maybe looking at how you can consult with your team and see what can be changed to improve that, especially if you didn't maybe achieve the goal that you set out to achieve, and then the next steps of how you want to kind of go about that. Yeah, just.
And sorry, Michaela here, I can add a little bit as well. I feel like some practices as well feel quite overwhelmed when implementing quality improvement activities, when your goals really don't need to be that big. So, I was with a practice today and, they thought, oh, well, we want to improve our cervical screening by, 70, but a crazy amount, but you really don't need to do that. And you can break up your quality improvement activities as well. Like you could do, you could start by sorting your reports using your data extraction tools by provider, do one doctor at a time, or you could do a certain age group. You can really narrow it down so it's not an overwhelming report to pull and it's more achievable. So just another thought I thought I'd add. Thanks.
Thanks, Michaela. We've got a question here for Kimberly, and I guess Alison as well. You can add, I guess, your experience. So working in medical centres, you can't do surveys or audits. It is not an option, and GPs have tried and asked about other measuring out options. So Kimberly or Alison, if you want to take this question.
I was just going to say there's another question there that talks about development of patient materials. And I think, something like that, if you developed patient materials, but again, you need to have some sort of a quality improvement outcome. So if you learn, for instance, that there's not enough information available to patients for that, you provided this, I just don't know how you're going to get the data back to show that change is making a difference. But we also recognize that measuring outcomes, there can be the point where you reflect and you implement changes. That's measuring outcomes. Then there's the other option where you go the next step and you actually look at how has that change helped or made things better. I think if you developed a learning materials for patients, because there is a need, obviously there needs to be a reason or some kind of improvement made to what is already available to them, because that in itself is not a measuring outcome. The other thing is it doesn't have to be as formal. There are lots of templates, and you've all talked about some really great things here that you may need. For instance, if you are getting Medicare benefits and you need to meet a certain requirement. But if you are working, say, like I said, you can record things informally. You can look at 5 patients. You can think about what you would do with that. You don't have to have a fancy template. You can make your own table. You can create that on your own, whether you use a spreadsheet or a Word document or a typical pen and paper to record that sort of information, as long as it's leading to some sort of quality improvement or the plan to improve something, a process, a system, a management, etc.
Great, thank you. Alison, did you want to add anything
I
to that?
don't look. I think that's the sticking point. It's it's that last part of it that we haven't quite got our head around. I haven't got my head around it either, so I certainly can't answer with any expertise. Literally, I'm just looking at the list of activities and I go, well, that fits with that. Quite frankly, I don't think you ever engage on anything without it having some sort of quality improvement for it. Like you see a need, and that's why you go and research it and do it. So that part, I think, is very easy. You don't do something that doesn't have a need. You see a need and you think, oh, I'd like to do a handout of that, or I'm going to research that because I don't think I'm managing that as well as I should, or maybe I shouldn't have prescribed that. Let me have a look and see what all the guidelines are, and maybe I'll change what I'm doing. So it's always an interactive quality improvement process, and you just got to write it down now, I guess. You were doing it all the time. It's the last bit you're talking about that I still don't quite, I mean, for me, it's often a reflection on how what I've done has either changed my management or how it has, I believe, changed what's happening with that patient. So like at the moment, I'm seeing a lot of young women with iron deficiency. So that was why I wanted to do the podcast on things people could do to keep their iron up, especially the vegetarians. So I think I saw a need. I think it's a quality improvement. I think it's going to be a really good resource that I'll recommend. But then how do I measure? Do I have to then ask the people that looked at it? Did you find that useful? They better say yes. Or how useful on a 1 to 10? Or do I look at whether they left nice comments? I don't know the last part.
And I think that's what makes the difference between, even when you look at audits, a mini audit is simply identifying and working up some sort of implementation of a change or an improvement. The full audit is going back and looking how well that change worked. So actually collecting data some way, whether it's through a survey or whatever it might be. I don't think you have to go to that full audit to say it's quality improvement, which I think is what you've been trying to say.
But can you say it's measuring outcome? Can you say it fits into the measuring outcome category? I guess that's my question. Can I say, I think I really need to help my patients with low iron. I've looked, there's no good handouts. There's lots of bitty handouts, but I've never found a really good one. And then I've got a wonderful dietitian. I'm doing a podcast with her and I'm going to have all this great information. I'm going to learn heaps, and then I've got something for my patients. So I saw a need. It was a quality improvement. There's an outcome. There's a podcast or a handout if somebody else does it. Is that enough to call it a measuring outcome, to go, here's my handout, or listen to my podcast?
Yeah. Look, we are actually defining measuring outcomes as being also quality improvement activities. So for instance, our clinical lead has a list of just 5 short little things, what you could do. And like one of them, if I read it here, select 5 patients with hypertension in a practice that you work in, make note of their treatment regime, note what their blood pressure control, compare that to best practice guidelines, and then and also your usual treatment that you provide. Make notes about what you've learned. Are there any gaps? Can I improve that in any way? And a plan to implement those changes. And that's where he stops.
Okay, I think it's, as I said, the general practice, the whole of general practice is you spend your whole time thinking, I need to know more about that, or I wonder if I did that right, or I need to do this for my patients. And I guess it's just about going, okay, turn it into a quality improvement activity, write up a little PDSA. And if you're studying it, you have to be measuring an outcome,
Yeah.
don't you?
Look, and I think the key is it does say that work data, so that you are looking, you're not simply choosing something, randomly, but that you're actually, I'm noticing this. This seems to be an issue. Even if it's 5 patients, with those 5 patients, I'm not doing exactly the same thing, or I should maybe be incorporating this and I'm not. So my typical way of managing this group of patients is this. According to best practice guidelines, it's slightly different. So what am I going to do to make that quality improvement change?
Kimberly, just following on from that, we've got a comment or a question about the 5 consecutive patients that you mentioned. What if someone's a locum or doesn't have those regular patients or, access to all those patients? How is that then a measuring outcome?
Yeah, and I think that's where this was actually written for a locum, because he was trying to say that if you have, X number of patients that you're seeing, you haven't seen them, before, they're coming in for the first time, but how are you managing, but finding that common condition, if you will, or commonality amongst several patients that you can actually identify. Is there a way in which I can improve how I manage or provide treatment or resources, whatever it might be for that particular patient or that particular condition within a group of 5 patients? So I guess it would be looking at your patient base. And again, if you're collecting information, you don't want anything, you don't want to identify those patients. You could be writing, you would know yourself who they are, but if it's a 36-year-old female with this who, is asking to use Ozempic, do I actually use the same protocol every time when someone comes up with that? Do I need to, what are the sort of things that I need to improve how I answer the questions to or provide resources for, etc. That was just off the top of my head. That seems to be quite a topic of at the moment.
Yeah. Thank you so much. I just want to thank all of our speakers for their time tonight. I realize just that we've gone on 8 o'clock. Alison, if you could give, I guess, one suggestion or one tip to the GPs out there, what would it be?
Oh, there's so many. I guess just any idea, think of it as how you can turn it into a quality improvement activity, because it's not that hard. And then how you can then generate CPD hours, not points, hours from that, because really we do it all the time. It's the nature of the work that we do. So that would be, and as I say, if you can take everyone along on the journey with you, it's been a lovely experience in our practice to do it together.
Great, thank you. Thank you very much to all of our speakers, to our panelists, to everybody behind the scenes who's been answering questions. If you do have any questions, we are all here to support you. So reach out to the practice support team, digital health team, the RACGP, and obviously the CPD team as well. So again, thank you very much. Alison, your experience, thank you so much for sharing that with us. And Kimberly, your knowledge and all those great tools that will be available for GPs. So thank you, everybody, and enjoy the rest of your night.